Welcome to part 6 of our 7-part series on organizational and occupational psychiatry topics for residents. I'm Parker Schwab. I'm a current PGY4 psychiatry resident at the timing of this video. I'm going to thank my assistant author, Sam Gardner, and then my advisor, David Morrison, on helping complete this curriculum and mentoring me through this process. So we will go forward. Before we begin, I wanted to just note that we don't have any conflicts of interest or financial disclosures at the timing of creating this curriculum. We will be using the org psych term to both encompass psychiatric and psychology topics. But please note that these are distinct fields. However, they do often overlap. So just to keep that in mind throughout this lecture series. So this is a bit of a bigger topic today to cover. So I've actually split it out into 4 different sections. It's going to be a bit longer of a video today because it's just a lot to cover, and this is probably the bulk of the material from the lecture series. So the first section is on disability and impairment, what it means, and kind of the definitions. The next section goes over leave of absence considerations if a patient is coming into you asking to take off time at work. And then we'll go over basic FMLA evaluations and what those look like and the considerations of that. And then we'll get into more advanced evaluations that require a little bit more robust evaluations, diagnostics, and then more formal written documents for legal proceedings that most psychiatrists don't do. They often refer out for these types of evaluations, but some do get training in this. So just to briefly go over disability and impairment, this slide is just to show that there's numerous definitions of disability from different organizations. I'm not going to go through all of these in detail for purposes of time, but we'll focus on the ADA as that impacts most of our patients in the United States. They defined disability as physical or mental impairment, which substantially limits one or more major life activities. These next couple slides are there to help us kind of understand what disability and impairment are and kind of the differences between the two of them. So disability is actually administratively determined based off of provider impairment descriptions. So as a provider in psychiatry, we actually are commenting on impairment and not on disability, as that's determined by a judicial decision. But the World Health Organization does define impairment as loss or abnormality in a person's psychological, physiological, or anatomical structure or function. So the framework to the right, or the schematic to the right, just kind of goes through and shows you that at the top, disability is determined by an administrative or judicial decision. There are 2 main components to this. One is the finder of fact, which is either a claims administrator, judge, or judicial tribunal, which then helps determine disability. And then there's the psychiatrist or other expert that's offering opinions on impairment that are resulting from psychiatric conditions that's then used to determine disability. If we are the provider offering opinions on this, we always have to provide an opinion on whether there's a causal relationship between the injury and the psychological condition. And we also have to opine on whether or not the impairment is either temporary or permanent. These next couple slides are tables that go over various definitions from the American with Disabilities Act. I'm not going to go through these in detail, but they're here for your reference. I do find that they're pretty helpful. So as you go through this, going back and maybe reviewing this would be a good thing to do. This next slide is more of a graphical representation of kind of what those tables before were commenting on. So I felt like this might be a better slide to cover than all of the words of the previous slides. But with the American with Disabilities Act, I tend to think of it in terms of 2 broad categories, either employed patients or unemployed patients. So if you have an employed patient, they're covered under the Family and Medical Leave Act, and then also can be covered under short-term and long-term disability insurance plans under FMLA. That does protect their the patient from being fired for up to 12 weeks of unpaid leave. Short-term and long-term disability can protect an employee's pay when they are taking time off, and potentially could even extend to longer periods of time, greater than 12 weeks, depending on the individual policy in place. But do note that each individual policy, it can be different, and so you would have to look at the terms of each disability plan that the patient has. One thing to note here is that it's always the employee's responsibility to work with their HR departments to sequence FMLA, short-term disability, and long-term disability while they're out of work. It's not necessarily on the provider, and so it's really up to the provider to remind the patient that they are going to be the ones that need to coordinate this. It's just fairly impossible for us to do on the physician end. And then the employer is always encouraged to provide reasonable accommodations if they're able to allow continuation of the job by the patient. If the patient's unemployed, they're covered under the Ticket to Work program and the Job Accommodation Network. These are things that were established by the government that provide employment networks and vocational rehab programs that may be available to your patient if they're unemployed. So always discussing those options with them if you feel like it'd be beneficial. And that these programs also protect Social Security benefits as they are going through those programs. In addition, unemployed patients are covered under the Social Security Act. This determines eligibility for Social Security benefits. And in order to be eligible for those benefits, the condition must prevent normal work. It must be expected to last more than 12 months or result in death. And the patient can't perform any substantial gainful activity doing other work. And the definition of how much they're allowed to earn in order to be considered substantial gainful activity is on the previous slide. So that would be useful to review on your own. The next slide is more of a graphical representation of the types of disability evaluations. The first being FMLA, which we just kind of went over how it protects time, not payment, and it's usually 12 weeks rolling unpaid leave. The next ones are Social Security disability insurance evaluations, fitness for duty evaluations, private disability, personal injury, and workers' comp. The ones that are outlined in the orange box are not required to have a determination of cause. And then the ones in green, so personal injury and workers' compensation, do require a determination of cause. So those are a little bit more advanced and require kind of a more of a robust evaluation. And then I outlined all of the ones in the dotted red line or dotted red line box are evaluations that do have the possibility of litigation. So although some providers are familiar with and feel comfortable with doing things like private disability evaluations or Social Security disability, just be mindful that sometimes those will come back and you might have to provide a more extensive evaluation if the judge or the legal teams require it. So there are many limitations to leave and disability evaluations, the first being access to care. So there's limited participation of physicians in disability evaluations because we just don't get much training and doing these types of things. There's also language or ethnicity barriers, more common in rural areas, which may make it hard to do some of these evaluations. There's insurance issues as conditions developed on the job are routinely excluded from insurance coverage. And then psychiatrist training is pretty poor in this area. It often requires a forensic fellowship to gain comfort in doing these types of evaluations. When it comes to leave, there are many things that we want to consider for our patients. I think the best way to go through this is maybe through a case study. So hopefully it will pop up. It's been running a little slow right now. All right, so this is our case. This is Hope. She's a 35-year-old single mom. She says, I'm too depressed. I need to take time off work. She's been having some escalating depressive symptoms over the last 3 to 4 weeks, including worsening mood, anhedonia, avolition, increased sleep and appetite. In the setting of a recent separation from her partner, increasing demands at work, and child rearing responsibilities. It hasn't reached the point of active suicidal thoughts, but she has had passive death wish at times. She does feel like this is consistent with prior depressive episodes, but may be a little bit more severe than it used to in the past. Her past psychiatric history includes depression and anxiety managed by her PCP. She's had no hospitalizations, no suicide attempts. She's not currently connected with a therapist and has no prior psychiatrist. She has a medical history of hypertension. Her family history includes a mother with depression, no suicide attempts in the family. Her social history includes a bachelor's in political science, work. She works in human resources, has recently been given increasing responsibility due to a company acquisition. She's a single parent to a 3-year-old daughter. She lives in an apartment downtown, in downtown Chicago with her daughter. She's currently on sertraline 50 and amlodipine. All right, so what should we think about with Hope's case, and what should we consider with her taking time off work? So the evidence does support that the default should be keeping patients at work unless there's a clear plan to return to work quickly and at full function. They've shown that keeping patients at work is associated with the best outcomes. There's a pretty staggering statistic out there that the odds of returning to work within a patient's lifetime decreases to 50% at 12 weeks of being out of work, which I think is wild. They've also done a study that have shown that 60 to 80% of US lost work days is not related to any specific condition. And from a psychiatric point of view, there's really few absolute contraindications to being out of work. Those include things like active suicidal thoughts or homicidal thoughts, and then substance use disorders requiring urgent interventions. The key takeaways to taking time off work or considerations of leave include that separation from work can actually be an urgent situation and is associated with poor outcomes, as we went through in previous sessions. Work is often an integral part of a patient's functionality. It can be a source of pride, relationships, and identity. We should always default to keeping patients at work and returning to work as quickly as possible when we're able to. It is noted that leave is often sought due to interpersonal difficulties or hostile workplaces, which might not necessarily be a reason to take time off work. It might be more of an HR thing to handle. The role of the physician or us in this situation is to help the patients navigate these difficulties and try to figure out what would be best for them going forward. Back to our case. So after careful consideration of the risks and benefits of a leave of absence, you agree to allow Hope to take time off work and focus on her recovery from her depression. She asks you to complete FMLA paperwork for her employer, and you grant her leave. And then when she does ask you to complete the paperwork, what are the key things to consider with this? So this leads us into basic or FMLA evaluations. So one thing to note is that outpatient providers are often asked to perform disability evaluations for mental health conditions. The American College of Occupational and Environmental Medicine acknowledges that there's a lack of scientific literature regarding work evaluations. They've done prior reviews of disability evaluations and note that there's limited, there's low inter-rater reliability, and there's variable methodologies out there, which makes it fairly poorly generalizable. Notably, psychiatric disorders, including chronic pain, are now the leading cause of disability worldwide. And this has been going on since 2001, when the World Health Organization named major depressive disorder as the leading cause of global disability, ages 15 to 44 years old, and that's still true today. So when we're thinking about disability evaluations or impairment evaluations, there are several guiding principles. that include each individual is different, and that we should always focus on functioning over symptom relief, and that there may be some residual symptoms when the patient is at work, and that's okay. The patient should not be labeled as categorically disabled, but that they have specific limitations and specific contexts. Our focus should always be on work-oriented rehab or rehabilitation with tailored problem-solving strategies. We should work in multidisciplinary teams to optimize functionality as able. We always want to remember that return to work is an iterative process, and it's aimed at restoring function in a stepwise process. And then we always want to maintain objectivity when we're doing these types of evaluations with our patients. The number one thing here is that we always want to avoid medicalizing non-medical issues. So that includes things like workplace conflict, job dissatisfaction, or family strife. So things happening outside of the workplace. It's most notable that, or they've had studies that have shown that over 50% of leave has actually been taken due to non-medical issues. So we've vastly been over prescribing time off work for people when there could have been various other interventions that we could have offered that might have been less damaging. So if these are happening, we always suggest that the patient approach HR to help figure out if there are accommodations that can be offered at work to help them navigate these issues. And it might not be that we need to necessarily step in from a psychiatric standpoint, but we can always advocate for our patients if needed. When we're asked to do the evaluations and we've determined that this is a medical issue, we always first want to clarify what the employer requests. Notably, a patient can qualify for Social Security benefits with any DSM diagnosis if their symptoms are persistent and impairing. The caveat to this is that this does not apply to substance use disorders, so that's an important thing to note. We don't have much objective data to go on when it comes to our diagnoses, so we're often having to correlate symptoms and impairment with our mental status exam, so that's going to be an important thing to focus on. And then we also want to focus on performing an H&P with a focus on limitations on functioning. So in order to do this, you can always ask about the patient's day in a chronological fashion. You can ask for performance appraisals from HR if needed, and then you can also always get collateral from family and friends to help corroborate the things that you're hearing from your patient. You can refer to a specialist for additional evaluation if needed. This includes things like PT and OT, or a neuropsychologist, or a specialist in occupational psychiatry. And also at the core of all of this is that you want to really think about how the results are going to affect the patient. So being labeled disabled or on disability can really create a core belief in a patient that they may never actually return to work, and that can be potentially damaging. So we want to be cautious in navigating those discussions, and even in our consideration of if we want the patient to take time off work. In addition, you always want to think about how this might affect the employer. It might be that the patient requesting certain accommodations or taking time off may be viewed as a nuisance, and they may find these things or these requests unreasonable, and that might risk termination. So we have to be very mindful of the delicate balance that we've been asked to navigate. Thank you for your patience. It's been the slideshow is just kind of lagging behind. These next couple slides go through some helpful tables that I feel like will be good to go over. So the first is various symptoms and how to think about it in terms of looking for it on the mental status exam, or asking about history questions in terms of like cognitive domains, affective domains, and interpersonal domains. I won't go through this in detail, but it's a helpful thing to go through if you are doing this type of evaluation, as it can help you kind of figure out what to be looking for. The next slide is actually flow sheet or flow chart that was developed for primary care physicians in terms of doing disability evaluations. And I think it also applies to psychiatrists here as well. So if a patient requests a disability evaluation, the first thing you want to think about is if you're the patient's long-term or longitudinal care provider. And if not, then you always want to think about referring them to the longitudinal provider, as they would be able to know the patient a little bit better and opine upon or comment on more longitudinal data that might support the patient's disability or impairment. If you decide to do the evaluation yourself, you always want to clarify what is needed, including forms like FMLA forms, employer specific forms, any short-term or disability, long-term disability forms. If you don't feel comfortable doing the evaluation, you can always refer to a licensed occupational medicine physician or an independent medical examiner. People specialized in this and have done specific training to do these evaluations. If you do feel comfortable doing these evaluations, it would be helpful to schedule separate appointments for work-focused assessments, for discussions regarding return to work, and then also treatment options, because this usually takes a little bit longer of a time and it's hard to cram into a regular session with a patient. In addition, after you do determine if a patient meets criteria to take time off work or is impaired, then you would always want to schedule follow-up to assess the accuracy of your diagnosis, any progress towards treatment goals. If there are work accommodations that you offered that whether or not they've been helpful or not. You also want to consider additional referrals if needed, and then also reassess the timeline of their return to work, and if that needs to be extended or shortened. Here's a list of additional referrals to consider, including PT, OT, neuropsychological testing, IOP programs, any vocational assessment or counseling resources out there, return to work programs, psychiatry evaluations, which we would be doing, and then also occupational medicine if needed. So here are a couple example accommodations you can request from employers if patients have specific symptoms. So for fatigue, you can ask for increased time for breaks, asking for more flexible work hours. For issues with sleep, you can ask for limitations on rotating and night shifts. You can try to help patients coordinate their work with their sleep schedule. For panic symptoms, you can ask for an allowance of 5 minutes for breaks on every hour for on short notice. For irritability, you can ask for more focus on projects. You can ask for limited work or limitations on working directly with people. For hallucinations, you can also ask for the use of headphones, which a lot of people have found helpful. For concentration issues, you can ask for verbal and written instructions, increased time for learning. You can ask for limitations on distractions in the workplace, checklists if able, and then more defined priorities at work. For work anxiety, you can ask for more flexible hours, routine debriefs with supervisors, and then increased time for mental health follow-up. So back to the case. Hope does not feel like she would be able to return to work with accommodations due to the severity of her depression, and your mental status exam confirms this. You make the recommendation for Hope to start a PHP program next week and then transition to IOP for treatment for depression while she's out of work, and she agrees to this. So how can you best navigate this discussion with Hope? When it comes to return to work discussions, it's noted that this is not an exact science. Studies have shown that most patients do end up returning to work within weeks to months, which is fairly encouraging. You can always offer the return to work as a range, for example, like 4 to 8 weeks, and then revise as treatment progresses. And then also always remember that this is an iterative process requiring communication and follow-up with your patient. So the schematic to the right or the graphic to the right just shows that when we're thinking about effective return to work discussions, we always want to draw on the patient's abilities, resilience, and values. We don't want to focus on limitations. We always want to work collaboratively collaboratively toward a goal of returning to work with our patients. And then we always want to have good communication with both the patient and the workplace, and when possible, working with multidisciplinary teams to increase patient functionality. When it comes to talking about returning to work, setting expectations early is key. You always want to ask if the patient does expect to return to work, because that can help identify those at risk for delayed return. And then you also always want to ask about the level of self-efficacy that the patient feels at work, as this can also be an adequate predictor of time. In addition, there's a couple other strategies that you can do, including normalizing and validating the circumstances and emotions of returning to work, which may increase their sense of self-efficacy. You always want to normalize that symptoms don't actually equal impairment or loss of function, and that symptoms at return to, or residual symptoms at return to work are actually expected. You can also offer accommodations in lieu of time off when possible, which we discussed previously. You can also always talk to them about their performance reviews. If they're getting all positive performance reviews and they still feel like they're not doing well, this may signify that there might actually be a decreased level of self-efficacy or self-esteem. You always want to offer realistic reassurance and encouragement to your patient. You want to validate their fears of staying at work and help them navigate interpersonal issues at the workplace or home if those are going on. And then you also want to validate that the workplace is not an easy place to return, and that they will be able to do it, but it may be difficult, and things will improve over time. We want to empower them to problem solve and confront avoidance patterns. You always want to try to encourage them to see themselves at the center of the initiative. And then if needed, you can always refer them to a therapist. And in fact, in the majority of these cases, it probably would be helpful for patients to be seeing a therapist during this time. This again highlights that setting expectations early for symptoms and recovery is key. So the goal of treatment should always be returning to work as soon as possible. You want to target work-oriented interventions from the outset if able, including working with the HR department or the company if they're available. You want to normalize residual symptoms at return to work as expected, as we talked about previously. You also want to help patients realize that work may help them alleviate residual symptoms. And then always remind them that resting at home is not always beneficial to recovery. It might actually, in fact, be detrimental. There are several factors that are associated with patients returning to work earlier. Those include an increased sense of self-efficacy, active coping skills, lower age, increased communication with their supervisor, quality and continuity of occupational care at their employer, and then also their own motivation to return to work, which is a little bit self-explanatory. There are several things that are associated with later return to work, including depression and anxiety, comorbid mental health issues, higher age, lower levels of education, prior sick leave or extended leaves of absence, increased job stress, including recent reorganizations of the company, the threat of job loss, and then part-time work. All of those are associated with later returns to work. So just to be mindful of those. So the key takeaways for basic evaluations or FMLA evaluations, the goal is to return to work as early as possible, and that we can always offer accommodations if needed in lieu of taking time off. You always want to start the conversations around return to work early and reassess frequently and set clear expectations with the patient. If able, you always want to schedule separate appointments just for work evaluations and paperwork with the patient so that there aren't any surprises and that you have adequate time to address any questions or concerns and do the full evaluation. It's always okay to leave things blank. You don't want to fill out anything that you're uncomfortable with. In addition, we want to avoid medicalizing non-medical issues. And if that is going on, then we want to have them approach HR. And then if the patient's taking time off work, they should always be actively working on their mental health, because just staying out of work is actually not helpful um, for mental health. It may actually be counterproductive and detrimental. And so you want to think about maybe having them do a PHP IOP program or increasing the frequency of their appointments or therapy visits while they are taking time off work. So going back to the case, you set clear expectations with Hope, you communicate with her regularly, and you have clear documentation on all treatment expectations and expected dates of treatment and return. She completes the PHP IOP program after 8 weeks and returns to work without issue at the agreed upon return to work date, and she feels much better and thanks you for your time in this difficult time. So a pretty good result here. And the key was that we had clear communication. We set expectations for return to work early, and we had her do active treatment for her mental health when she was out of work. So moving on to more advanced evaluations, this is probably a topic that most of you might not do. So if you do feel like you're not going to be a provider that offers more extended disability or impairment evaluations, you can probably sign off now. But if you are interested in more, that you're more than welcome to stay on, and I'll go through some of the more advanced techniques. This is just to, again, describe how after FMLA, most of these evaluations do have the possibility of litigation. And so you want to start thinking about them in a little bit more of a robust way and have more of a strategy as how to approach these. So going forward, when do you want to start considering doing an impairment evaluation? So first, you want to think about the priority being their returning to the job of injury. So you should always make sure that your reasons for a patient taking leave should be based on objective determinations. This can include things like physical evaluations from PTOT or neuropsychological evaluations. If they're not able to return to their job of injury, are there any transferable skills? Can they participate in training? Or are there other prior experiences in a closely related job that they can go towards? If they're not able to do that, are they able to explore options for gainful reemployment? Can they complete any additional degrees or certifications that might make them more employable? Or can they complete vocational programs? If they're able to do any of those things, you can always consider having them take off time for leave, such as FMLA or short-term disability, to provide time to complete these items. Otherwise, if they're not able to do these things, then that's when you really want to start thinking about impairment and doing a full evaluation. So when you do more advanced evaluations or impairment evaluations, what do these look like? So forensic disability assessments incorporates the following: robust clinical psychiatric interview, comprehensive record reviews, job descriptions and job analyses, collateral, and then also psychological and medical testing as needed. Before we get to all of the schematics of how you actually do one of these evaluations, I do want to highlight that there's actually no formal requirement or specific training for disability evaluations, but experience is beneficial. Your skills and diagnostic acumen improve over time, and as you gain experience, there's less influence from countertransference in these evaluations. You always want to be mindful of ethics and self-monitoring. So if you're doing an evaluation, you want to think, is my opinion consistent with past similar circumstances? Do I feel comfortable defending this in front of a jury? Is there anything in the evaluation that doesn't feel right or doesn't pass the smell test? And those can be all things that are red flags for you to maybe hold off on the evaluation or reconsidering. So there are several requirements for individual medical evaluations or individual medical examiner evaluations. One being vocational review. So this includes describing the physical, mental activities associated with the job. In order to do this, you can always employ the Fischler and Booth vocational impact of psychiatric disorders as a good resource that describes each diagnose's impact on work functionality. You also have to go through a full impairment description, which includes whether or not the condition is sufficiently severe enough to preclude gainful employment, whether the examinee can perform some functions and not others, and that includes descriptions of limitations, which is the activities that the examinee cannot do, and then also a description of restrictions, which are activities that the examinee should not do. In addition, you have to provide impairment ratings, and so these must be provided through a dimensional impairment rating according to statute criteria within the individual states, and then also the AMA guidelines, which we will go through. It is important to note that the impairment ratings are often inconsistent between examiners due to lack of training and research, and also just the confusing legal landscape. But it is important to try to triangulate or cross-correlate multiple rating scales to try to make your evaluation more consistent, which we'll go through in more detail. So for dimensional impairment ratings, cross-correlating multiple rating scales and psychological tests will improve your consistency and reliability of your court testimony. One of the main psychological tests that is currently employed most frequently is the MMPI-3, as that is generally believed to meet the standard in forensic testimony, or for the standard for forensic testimony, and we'll go through that a little bit more in subsequent slides. But when it comes to cross-correlating multiple scales and definitions, you want to look over the various definitions that are provided in the AMA Guide to Evaluation of Impairment. You also want to look at your own individual state definitions. For example, Washington State has the categories for evaluation of permanent impairments of mental health. So you can always use that to help cross-correlate, or you always can use that to cross-correlate with the AMA Guide. And then also you want to use your psychological testing results to cross-correlate as well. So what is the role of the independent medical evaluator for a psychiatrist? So when you do these evaluations, you always want to be the independent seeker of truth. You want to offer unbiased opinions. You always want to avoid establishing a doctor-patient relationship or act as the treating clinician, because that could always create conflicts of interest. In addition, you want to provide early notification to all parties with clear and substantial reasons if any exceptions are made. When you become the independent medical evaluator, these are often requested either routine or requested by the litigator, such as the attorney, insurance providers, or employer or government agency. The claims manager often requests updates in half-year to 1-year intervals. When you do get an IME request, it should include an assignment letter, which defines the purpose of evaluation, the questions that need to be addressed. If this is not provided, you should always ask for one, as that will help decrease the chances of any misunderstandings. The requester should provide records necessary for evaluation. It's the examiner's responsibility for requesting any missing records, and if there are any critical missing records, it needs to be adequately reported in the report. As always, it's really important, or you have to discuss informed consent with the patient, any restrictions of release of the documentation, and then also it's important to discuss your fee arrangements prior to the evaluation. This goes through various disability evaluations in some detail. So the first one that we'll go through is workers' compensation. This requires an apportionment of causation between the workplace and unrelated factors. You have to include severity ratings, both pre and post-injury, according to statute. There is a degree of restriction. You also have to comment on the degree of restriction to perform duties without accommodation. You also have to assess if there is either permanent or temporary impairment, and also describe limitations and restrictions. You also have to provide treatment reports every 60 days to insurance companies, and that you have to remember that patients are always entitled to this, any correspondence between the insurance company and the provider. Moving on to fitness for duty evaluations, this is required when there's a question if a patient is able to perform their job safely. Referral letters outlining the reasons for evaluation and questions to answer is required. So if you don't get that, you need to make sure you request it. In these evaluations, you're usually not required to do a developmental history unless it's relevant, which is in contrast to workers' compensation and social security evaluations. Remember that fitness for duty evaluations are profession specific. So for example, a law enforcement agent or a law enforcement employee is going to have a different evaluation than, say, a physician. There's always potential for misuse by employers. So if you do feel like there's a suspected hidden agenda, then you want to always decline the request to do an evaluation. For Social Security disability, this is administered under the Disability Determination Services branch of the Social Security Administration. This typically acts as a backup benefit for workers' compensation. The Disability Determination Services Agency will supply records for review. This is often less complex than workers' compensation. It doesn't really require a determination of causation, and generally testimony is not required. You do, however, have to provide an opinion on the duration and prognosis of treatment and the ability of the patient to manage funds. And then if this is denied, it can always be appealed. There may be additional psychological testing that is ordered by the judge or attorney. They look for opinions on if the claimant meets the definition of mental disorders. And these definitions are similar to, but not identical to the DSM. In fact, they're contained in the Social Security Blue Book and Psychiatric Review Technique form, which is all available online. If the patient does meet criteria for a mental disorder diagnosis, then a mental residual functional capacity assessment is completed. Again, these are all if the Social Security disability evaluation is denied. Often all of these things are required in the appeal process. So if you are appealing and you do require a mental residual functional capacity assessment, I'll go through that in the slide. So the MRFCA lists 20 mental capacities across 4 different categories of mental functioning, including categories of understanding and memory, sustained concentration and persistence, social interaction and adaptation. I went over a little bit of these more in detail in each box, which I won't get into right now just because of time, but please review those on your own. And then in addition to doing the assessment, you have to comment on the severity using the 5 severity ratings listed below. So it's a bit of a robust evaluation and may require some practice with it, but hopefully it'll be fairly straightforward. So now we're getting into how to actually do the interview with the patient and what's required in the evaluation and report. So in the report, there's an introduction. You have to include demographic data, including age, gender, ethnicity, marital status, members of the household, statements of non-confidentiality, and then informed consent, and also the chief complaint. You have to comment on your records review, which details the records or documents that were reviewed. This often requires recording the relevant facts of the document line by line, and it can be quite tedious. And then just noting that sometimes the evaluation may be determined inadequate if every page of the record is not read. So it does require you to read every single page of the reports that are given to you. You then have to go through a full employment history, which includes elements central to the personal functioning, impairment, and disability of the person. You have to comment on jobs previously held, any changes, promotions, or dismissals. This can often help reflect the patient's aptitude, adaptability, and capacity to take orders, ability to cooperate, and any leadership capacity. In addition, you have to comment on medications, including current and past medications, prior diagnoses, side effects of the medications, and also medical conditions. You then want to comment on the past psychiatric history, including hospitalizations, which may suggest vulnerability to occupational stress and less adaptive capacity. You also have to comment on prior outpatient treatment. If there was any prior to the job event and there's consistency across time, it may suggest that it may not be related to the job. You then want to comment on family history, including factors influencing early development and genetic susceptibilities, including things like suicide attempts, any major mental disorders, alcohol or other substance abuse in the family, or trauma. The past medical history is also an important component. You have to weigh in on medical contributions to the possible mental impairments. For example, things like thyroid disorders may actually be contributing to depression or anxiety, and you need to comment on that and how much of the extent that you think that it is contributing. For developmental history, you want to look at the parents' work experiences and behaviors and attitudes towards work, which sets an example for the patient. You also have to comment on any neglect and abuse, which may increase the risk of mental health disorders and may affect the prognosis for returning to work. You want to focus on educational history as well, including academic aptitude, school quality, parental support and resources, housing stability, and ability to sustain effort. For social history, you want to comment on marital history, any children and parenting responsibilities that they have. You want to focus on military history if there is any, if there are any Article 15 proceedings or less than honorable discharges that might suggest authority issues. So that would be important to comment on. You also want to comment on any legal history, including arrests and convictions, which may suggest an underlying personality disorder. And also these can limit job opportunities. DUIs may also point to substance use disorders. So you do want to hone in on any substance use history as well, which will reflect overall functioning of the patient. And then you want to really look into the social support of the patient and any leisure activities that they participate in, as it might give you a little bit more insight into the patient and the patient's personality and their ability to adapt. Then you want to do a full mental status exam, which is the same as any routine psychiatric evaluation, but you do want to examine them specifically for their ability to meet essential duties of their occupation. For example, really hone in on any cognitive deficits or cognitive testing for people who require that, including people who are in the airline industry. You also want to go through special considerations at the very end of the evaluation, including trying to find collateral if you're able to corroborate findings. In addition, you should always consider fraud and malingering in each exam. However, it is important to note that worker fraud is actually less common than employer fraud, and so just be mindful of that. And then you always want to be objective, and if you do feel like the patient is being deceptive, you need to maintain neutrality and then find evidence and support that in your report. To help support your claims or your report, you also want to always try to include psychological scales or any additional medical tests or labs that might be supportive of that. They do recommend the Minnesota Multiphasic Personality Inventory, which is often used in forensic evaluations. However, this does require special training. It doesn't always have to be included, but it might be something that might be helpful to include. Any prior or any scales that are self-reported or lack validity, like the BDI-2 or the PHQ-9, often are not viewed as reliable in forensic testimony, and so they're less relied upon. So just to be mindful of that as you complete your evaluation. Once you've done your full interview and your evaluation, you then have to do the summary, which is often written with a holistic style or quality. It should always try to evoke the personality of the examinee. You want to always focus on clarity and lack of jargon, as your audience is largely legal and not medical providers. You also want to address any questions that are posed by the requesting party, including the following: diagnosis, apportionment of causation, degree of impairment, whether it's partial or complete, any treatment recommendations, if there's been maximum medical improvement achieved, and can the patient return to work with or without accommodation, and would they benefit from vocational services? So that was a lot to go through. It was our longest section. I think it was hopefully one of the more informative and helpful sections of these presentations, as I feel like we don't really get a lot of training in this area as psychiatry residents. And hopefully it'll make you feel a little bit more confident going into discussions with your patients about going on leave or taking time off work, or even asking for impairment evaluations. With that, I will end for the day, and I hope this has been helpful. And yeah, I wish everyone the best of luck in their careers. Thanks.